Dr. Jaimie Nathan is a professor of surgery at The Ohio State University College of Medicine and chief of abdominal transplantation and hepatopancreatabiliary surgery at Nationwide Children's Hospital, where he holds the Nationwide Foundation Endowed Chair in Pediatric Transplantation and serves as the surgical director of the TPIAT program. He received his medical degree from Yale University and completed surgical training at Duke University, Cincinnati Children's Hospital, and the University of Cincinnati. Dr. Nathan has devoted much of his career to treating children with acute, recurrent, and chronic pancreatitis, particularly those with debilitating pain and poor quality of life. He has extensive experience in the multidisciplinary evaluation and surgical treatment of these children, with particular expertise in total pancreatectomy with Islet Auto-Transplantation, TPIAT. He is one of the most experienced pediatric TPIAT surgeons in the world, having performed more than 130 procedures in children and adolescents. He has also played a central role in developing and building comprehensive pediatric pancreas programs at both Cincinnati Children's Hospital and Nationwide Children's Hospital. Dr. Nathan has served as co-investigator in the NIH R01 funded multi-center prospective observational study of TPIAT post, which has helped define outcomes following the procedure across major U.S. centers. He is also a co-investigator with INSPIRE, International Study Group of Pediatric Pancreatitis, in Search for a Cure, a multi-center consortium dedicated to advancing the understanding and treatment of acute, recurrent, and chronic pancreatitis in children. He has published extensively and lectured nationally and internationally on pediatric pancreatic disease and transplantation.
Hi there, my name is Jaimie Nathan. I'm professor of surgery and pediatrics at The Ohio State University College of Medicine and chief of abdominal transplant and hepatopancreatabiliary surgery at Nationwide Children's Hospital. I'm honored to be here to present on total pancreatectomy with Islet Auto-Transplantation in children. I have no disclosures. So the objectives today will be to identify options and decision-making algorithm for the surgical management of debilitating pancreatitis in children, to summarize techniques and complications of TPIAT in children, and to analyze outcomes and future directions of TPIAT in children. So let's start with the scope of the challenge of surgery for chronic pancreatitis in children. So we recognize that pancreatic disorders are increasingly reported in children. The literature on chronic pancreatitis in children remains limited, however, and in general, there's a limited pancreas experience of pediatric surgeons. And over time, the surgical approach has typically been extrapolated from adult data, but we have to recognize that there are differences in etiologies and morphology of disease when comparing adults to children. And we are always looking to offer the right operation in the right child at the right time. So just as a background, chronic pancreatitis is, of course, progressive, irreversible fibroinflammatory destruction of the pancreas. There are a variety of risk factors. In children in particular, genetic risk factors play an important role, but there are, of course, other obstructive and anatomic risk factors. And chronic pancreatitis in children can present with varying degree of inflammation, fibrosis, ductal abnormalities, and likewise a variable degree of pain, exocrine insufficiency, or the occurrence of diabetes. Overall disease burden is high, however, and in a cohort of children, there are substantial hospitalizations, radiologic studies, interventions, and really some patients, some children end up with chronic pain, opioid dependence, and very severely impaired quality of life. So the overall treatment goals for chronic pancreatitis are to relieve the acute and chronic pain, to calm the disease process, to prevent repeated attacks, and of course to address the metabolic consequences, those being diabetes, exocrine insufficiency, malnutrition, and of course manage complications of chronic pancreatitis. When maximal medical and endoscopic approaches fail to relieve pain and to address specific complications, that's when we consider surgical procedures. So this slide highlights indications for surgery for chronic pancreatitis. Overall, approximately 50% of patients with chronic pancreatitis eventually require some type of operation. The classic indications are highlighted here in this diagram. Classic indications include biliary obstruction or duodenal obstruction due to the significant inflammatory insult, pseudocysts that cannot be managed endoscopically. Of course, in this day and age, most can be managed endoscopically. Suspicion of malignancy, although this is a much more common indication for an operation in adults with chronic pancreatitis, not so much in children. But the most common indication for an operation in chronic pancreatitis in children remains debilitating pain that fails to respond to medical and endoscopic treatment options. So when we talk about different categories of surgical options, we talk about conventional operations, and conventional operations can be broken down into drainage operations, such as a Pusteau or the Fry, partial resections, which may be a head resection with a Whipple operation or a distal pancreatectomy for tail disease, or combination drainage and resection operations that have been popularized, particularly in Europe, as duodenum preserving pancreatic head resections that include Bager and Byrne procedures. Now, those are conventional operations. When we talk about another option, that would be total pancreatectomy with Islet Auto-Transplantation. And so that's where there is a bit of a decision making that we need to talk about here in terms of what is the optimal approach, whether a conventional operation or a TPIAT. There are really very few reports of surgical interventions in children with CP, and they've been derived from very small cohorts, really without long-term outcomes reported. And so we really don't know how frequently surgical interventions are utilized or whether certain operations are favored over others in children. So when we consider the overall aims of an operation for chronic pancreatitis, the goal, of course, is to provide long-term pain relief, improve quality of life. We, of course, want to ensure low risk of morbidity and mortality. And of course, we want to maximize preservation of pancreatic parenchyma so that we can preserve exocrine and endocrine function. And we also have to ensure that we're addressing the local complications involving adjacent organs. Selection of operation must take into account anatomic and morphologic features of the pancreas. Importantly, and what we have been learning over the last 5 to 8 years or so, or 5 to 10 years, is that the presence of an underlying genetic risk factor for pancreatitis may also impact the outcome of an operation. So when we talk about morphology of disease, this slide highlights on the left here large duct disease, classically seen in adult patients, less so in children with chronic pancreatitis. But you can see that the main pancreatic duct is uniformly dilated from head to tail. And this might be addressed with a surgical drainage operation, a Pusteau or a Fry procedure. In the center here, we see what has been termed the pacemaker of disease, an inflammatory mass in the head of the pancreas, highlighted by the white arrow. And this has been addressed by head operations, so either the Whipple operation or sometimes those duodenum preserving pancreatic head resections. And then on rare occasions, we have a disease that is really isolated to the tail, focal tail disease, that may be amenable to just a distal pancreatectomy. So the reality is that there's no single surgical procedure recommended for all children with chronic pancreatitis, and we have to consider morphology of disease, the anatomy of disease. Now, the rationale for a drainage operation for large duct disease is that the pain in chronic pancreatitis is due to hypertension in the pancreatic duct, so high pressure in the pancreatic duct, and that with decompression of this large duct disease, we would relieve pain. This has classically been addressed by the modified Pusteau operation. It's historically the most common drainage operation, whereby, as shown here in the figure, the large pancreatic duct is open from head to tail, and then a Roux-en-Y jejunal limb is sewn to that opened pancreatic duct. It's relatively simple, low complication rate. It obviously preserves parenchyma. We're not removing any pancreatic parenchyma here. And it does achieve short-term pain relief in up to about 75% of patients. However, about 50% of patients, at least 50% of patients, do suffer from recurrent pain. And in these circumstances, it's believed to be related to incomplete duct decompression or continued inflammation in the head of the pancreas, or the presence of a genetic field defect. So those patients that have genetic risk factors for disease, we're not fixing the genetic risk factor with a Pusteau operation. And so really this type of operation might be most promising if the duct is substantially dilated from head to tail uniformly without the presence of an inflammatory head mass and without an underlying genetic risk factor. Now, we can't really take a hammer and nail approach when we're talking about surgical drainage operations. And so we should not just be addressing every dilated duct with a Pusteau operation. So the Fry procedure is a modification to the Pusteau. It is another surgical decompression or surgical drainage operation where it includes a coring out, a relatively limited coring out of the head of the pancreas, in addition to opening up that pancreatic duct all the way to the tail. And this coring out of the head here removes a portion of the pancreas that's really at the highest risk of progressive inflammation. In adult studies, it does achieve pain relief in over 85% of patients. And there have been a few small pediatric series that have reported excellent or good outcomes in about 3/4 of patients, and pain resolution in about 90% at modest follow-up of about 30 months after operation. And really, in most high-volume pancreas centers, the Fry actually is preferred now over the Pusteau due to superior long-term outcomes if one is considering offering a surgical drainage operation. Now, what about disease in the head of the pancreas, so the inflammatory head mass? So the rationale for pancreatic head resection is that this inflammatory head mass contributes to obstruction of ductal drainage, and alternatively, or perhaps in addition, the presence of perineural inflammation in the head of the pancreas actually significantly contributes to pain and chronic pancreatitis. And so the operation to address inflammatory head mass in the pancreas has historically been the Whipple operation, pancreatitis. Now, the advantage here is that it achieves complete resection of the head of the pancreas, so it really removes the possibility of disease recurrence. But the disadvantage, of course, is that there are some non-disease organs that are also impacted. So the bile duct is removed, the duodenum is resected, and these all require reconstruction. It does have a low mortality, but the risk of morbidity is not small. The risk of morbidity is related to anastomotic leak from the connection to the jejunum, to the remnant body and tail. And in adult studies, it does achieve good pain relief in adults with chronic pancreatitis, about 80% at 6 years. But there's a pretty high risk of late endocrine and exocrine insufficiency, over 50% for each, actually. And really, in general, this is uncommonly utilized in children, largely because children do not typically present with an inflammatory head mass when they present with debilitating pancreatitis. Now, duodenum preserving pancreatic head resections are alternatives to the Whipple operation. And again, the goal is to resect the inflammatory head mass. These operations do preserve the duodenum and preserve the bile duct. And it's also somewhat limited. They're somewhat limited in terms of the extent of parenchymal transection or resection, excuse me. And it does, these are combined drainage and partial resections, the Bager at the top here, the Burn below. And these do achieve pain relief also in about 85% of adults, and they have lower risks of endocrine and exocrine insufficiency, as you can see here, about 10 to 34% for exocrine, 10 to 26% for endocrine insufficiency. So lower risks than Whipple operations. However, these two are uncommonly utilized in children, but again, largely due to the absence of head masses, inflammatory head masses in children with chronic pancreatitis. Now, the impact of these conventional operations in children with chronic pancreatitis is really not well known. Again, small sample size, short duration of follow-up of these studies. And again, not to belabor the point, but fewer children have large duct disease or an inflammatory head mass. So conventional operations are not indicated in small duct disease. So we have to remember this. And importantly, what we have learned over the last 5 to 10 years is that the presence of underlying genetic risk factors may actually negatively impact the outcome of conventional operation in children. So in one long-term study, about 2/3 of children with hereditary pancreatitis continued to have symptoms of pancreatitis, most requiring hospitalizations over 15 years after a Pusteau operation. In another small study, children with hereditary pancreatitis were less likely to have sustained improvement in pain after Pusteau, and required salvage TPIAT. And so importantly, children with genetic risk factors more commonly have a suboptimal response to conventional operation for chronic pancreatitis. And so these children and families need to be counseled regarding the pros and cons of conventional operation versus proceeding with TPIAT. So conventional operations can result in initial pain relief, but pain does recur in approximately 50% of patients over the long term after conventional operation. So a failure of a prior conventional operation is an indication for total pancreatectomy with islet auto-transplant. And again, importantly, debilitating chronic pancreatitis or acute recurrent pancreatitis without a conventional surgical option. So those that have small duct disease, that's an indication for a TPIAT. So the primary goal of the operation of TPIAT is again to relieve incapacitating pain and impaired quality of life when all other measures have failed. The secondary goal of the operation is to preserve beta cell mass and insulin secretory capacity to prevent or minimize postoperative diabetes. And so this is the secondary goal. And so patients that come to us sometimes this has to be clarified with families and patients because there's a lot of attention to, well, insulin independence. But really, it's important to ensure that the primary goal is understood, which is to relieve the pain and improve quality of life. So what does this take? This does take a very large multidisciplinary team highlighted here. So it's not just about surgery, gastroenterology, and endocrinology, but genetics, understanding the underlying genetic risk factors, as the majority of children with debilitating chronic pancreatitis or acute recurrent pancreatitis actually have genetic risk factors. Pain physicians, pain psychology, critically important in order for patients to develop coping skills and functioning approaches to really be able to come out on the other side with a successful operation. And then a radiology, of course, social work to assess a support structure and provide support as needed. Nutritionists are critically important. And then potentially, if one is recommended to proceed with TPIAT, the hematologists and infectious disease folks to understand if there's an underlying bleeding disorder or prothrombotic disorder, since islets are typically placed into the portal vein for autotransplantation, and infectious disease, since most TPIATs do require a splenectomy, and we'll get into that here shortly. The other critical component is islet isolation expertise. And so one cannot successfully achieve really most optimal outcomes without having an islet team, an islet isolation approach and experience. And this is critically important to outcomes with regard to endocrine function and glycemic control over the long term after TPIAT. So this highlights general criteria for consideration of TPIAT. So certainly institutions or centers might differ. There's some nuances to consideration of criteria for TPIAT, but this highlights some generally agreed upon criteria. So objective criteria meeting the diagnosis of CP or ARP lasting at least 6 months. Criteria consistent with debilitation by virtue of opioid dependence or significantly impaired quality of life. So a patient does not need to be opioid dependent to be a candidate for TPIAT. It's critically important to understand that. Patients with acute recurrent pancreatitis that actually don't even meet criteria for chronic pancreatitis yet, those patients might similarly be debilitated and have significantly impaired quality of life if they're in the hospital very frequently, every 4 weeks, every 6 weeks, so having numerous long hospitalizations each year. That's debilitation as well. Absence of a reversible cause of pancreatitis, failure to respond to maximal medical and endoscopic therapies, and absence of a physiologic or psychosocial contraindication to operation, and adequate underlying islet function. So when we consider preoperative considerations, so are there any underlying cardiac or pulmonary comorbidities? Is there an underlying bleeding or clotting disorder? How's the nutritional status of that patient? Are immunizations up to date related to OPSI? Have there been prior abdominal operations, prior pancreas operation, presence of ongoing pseudocysts in the abdomen or significant inflammation when we proceed with a TPIAT or really any conventional operation on the pancreas? We really would like the pancreas to be quiescent. We don't want a lot of fluid collections in that space. What is the liver volume? And so this is important to consider when we have very young patients that may require TPIAT. Is there any underlying advanced liver fibrosis? Is the portal vein patent, since this is where we typically will auto-transplant the islets? And what does the hepatic arterial anatomy look like? Because in a percentage of patients, normal variants of hepatic artery inflow occur, such as replaced or accessory right hepatic arteries, and those arteries can actually traverse even through the pancreas, but certainly commonly behind the head of the pancreas, and they're very adherent to the back of the head of the pancreas, and so those need to be preserved and dissected off the pancreatic head at the time of a TPIAT. So it's important to understand hepatic arterial anatomy. This is how I perform the procedure typically. So obviously it involves total pancreatectomy. I do preserve the pylorus in the first portion of the duodenum, so it's a near total duodenectomy. Splenectomy, in most cases, the decision can be made in the operating room whether or not the spleen can be preserved. And this is really driven by how densely adherent the pancreas is to the splenic vessels. And cholecystectomy is performed, appendectomy, since it would be unfortunate for a patient to end up with appendicitis after TPIAT, so we do take the appendix out. All patients universally have some degree of delayed gastric emptying, so we do place a gastrojejunal feeding tube at the time of operation that is in there for several weeks after TPIAT to allow for downstream feeds to be administered early after operation. And then we do inject pyloric Botox in the pylorus to hopefully mitigate the delayed gastric emptying after operation. So here in this panel here, you see the superior mesenteric vein. You see a little splenic vein stump right here. This is a case where we could not preserve the spleen. And then these join to become the portal vein right here. So after the pancreas is removed, our islet team comes over and retrieves that pancreas. It's in preservation solution, it's on ice. And the goal of the islet isolation is to digest the pancreas to really disrupt the exocrine tissue and release a relatively pure islet prep. It's not a completely pure islet prep, but we really want a very small tissue volume to be able to safely infuse it into the portal vein. It's a combination of mechanical dispersion as well as enzymatic digestion, and this typically takes about 5 hours or so. If there's an additional purification step, again, not to completely purify the islets, but to further decrease the exocrine component of the prep, that adds some time as well. And that final pellet is assessed in terms of count, etc. During that islet isolation process, which again takes at least 5 hours, we are reconstructing bile duct drainage, the alimentary tract, and this is how I prefer to do it. It's with basically 2 Roux-en-Y jejunal limbs, so a limb up to the bile duct, and then a limb up to the duodenal stump right here. And typically we do have a little bit additional waiting time once we're done with the reconstruction and placement of the GJ feeding tube. We're typically waiting for those islets to come back for an additional hour or sometimes hour and a half. When those islets come back to us, we are very careful and cautious about how we infuse these islets. Critically important, and it's very, very nuanced. And so right here, you see a little cannula into the splenic vein stump in the picture right here. With a very significant tissue volume, the portal pressure increases substantially, and that leads to reduced flow and a risk of portal vein thrombosis. So these islets get released into this portal system, and they really go up into the very terminal branches of the liver, and they get jammed up there, and they cause a back pressure. So every patient gets an increase in portal pressure during and after islet autotransplantation. So we are very, very cautious about how we infuse these islets. And so every patient is heparinized, And then portal pressure is monitored. I measure portal pressure every 5 minutes. I pause the infusion and assess how high the pressure is going, what's the trajectory of the increase. We know from adult data that a change in pressure of over 25 centimeters of water is associated with a 10-fold higher risk of portal vein thrombosis. So we are very, very cautious about how we infuse islets so that we can mitigate the risk of portal vein thrombosis. Pressure will rise in every patient. We sometimes will pause the infusion, allow autoregulation to occur, and often that pressure will come down enough to continue infusion of islets into the portal system. But at some point, the portal pressure may remain uncomfortably high. This is a judgment call of what that is really. And then the remaining islets are auto-transplanted into a secondary site, sometimes into an omental pouch, sometimes into small bowel mesentery, etc. Postoperatively, patients are monitored in the ICU, pediatric ICU, for generally 6 to 7 days. We monitor for issues with the portal vein with Doppler ultrasound. We continue anticoagulation with heparin. We do utilize dextran for the first 48 hours. It has an antiplatelet effect. It also helps to mitigate the instant blood-mediated inflammatory response of the autotransplant. And importantly, we manage blood sugars very, very tightly between 80 and 120 because we know from significant data, particularly in animals actually, that with islet autotransplantation, if there is exposure of those islets to prolonged periods of hyperglycemia, that causes significant apoptosis, and those islets will not survive and engraft. And so we monitor things very closely in the ICU with hourly blood glucoses via the arterial cannula, and we also utilize a continuous glucose monitor as an additional tool. Patients are on antibiotics generally for 72 hours and then thereafter convert to OPSI prophylaxis. Tube feeds get advanced, typically starting day 3 after operation and then advanced thereafter over the several days, so that typically by the time we're leaving the ICU at 6 or 7 days, those feeds are at full feeds. And then, of course, every patient does require lifelong pancreatic enzyme replacement therapy after TPIAT. Since we're not, of course, giving back exocrine function with an islet autotransplant. And then once a patient leaves the ICU, goes to the floor, they are changed over from an insulin infusion to insulin pump therapy. And every patient, very importantly, every patient comes into this operation with different pain needs. And so every patient has an individualized pain management plan. Patients that are then on the floor for typically at least another 7 days, 7 to 10 days. So overall, the hospitalization is somewhere between 2.5 weeks in general. And on the floor is where there is lots of teaching that goes on. How do you manage an insulin pump? How do you address the continuous glucose monitor, diabetes, insulin education, counting carbs, etc., feeding tube education, etc. So obviously a big operation, and so big operations do have risk. And so I balance risks of bleeding and portal vein thrombosis very cautiously. I always tell families that I'm counseling for TPIT, similar to liver transplant evaluations, I rather deal with a bleeding problem than a clotting problem. And I do prefer to maintain patients on blood thinner to really mitigate portal vein thrombosis. In the first column, in the middle column here is the literature reports of bleeding and clotting issues. Portal vein thrombosis reported 4 to 8%. In over 130 cases now, I've had only a single case of portal vein thrombosis. And so we do ensure mitigation of that risk. And then likewise, anything we sew together, of course, can leak. But in our hands, I haven't had a single leak from any of our anastomoses in any of our patients. Doesn't mean the risk is zero, of course. So universally, every patient does get a systemic inflammatory response. This typically resolves over a few days. If patients are still having fevers by about 6 or 7 days, we'll get a CT scan, see if there's a fluid collection that might need to be drained, but this is pretty uncommon. Every patient universally does get delayed gastric emptying, so hence the need for a gastrojejunal feeding tube for downstream feeds. Early after operation. Once patients are on the floor, we do back off on feeds. We start to give windows off of feeds to allow patients to eat, and then we continue to back off on those feeds as their PO intake improves. Other things that can occur that are not particularly predictable. Sometimes a patient may develop some gastritis post-op or an anastomotic ulcer. These are typically managed medically. Small bowel obstruction, also unpredictable, related to adhesions, and this may lead to a need for operation for adhesiolysis. And then in some circumstances, patients may get some hernias at the incision, at the fascial and muscle level that may need operation. Typically, patients are discharged locally from our program for 2 to 3 weeks, stay locally for 2 to 3 weeks, and then we have very close follow-up the first year every 3 months, the next year every 6 months, and then yearly after that. A whole host of components need to be monitored. That, of course, we partner with our GI pancreatologists and with our endocrine team, et cetera, our pain team, pain psychology. So nutritional issues, assuring adequate pancreatic enzyme replacement therapy, vitamin and mineral levels, weaning of opioids. So this takes time, especially when patients come in with a very high opioid burden. Weaning of exogenous insulin. So islets don't start to work right away. So this does take time, of course. And our endocrine team does a great job of managing weaning of insulin. And then thrombocytosis, especially if the spleen has been removed, patients do get a very high platelet count, and we manage that with aspirin and hydroxyurea typically. And this is really in the setting of, again, trying to mitigate a risk of portal vein thrombosis post-op. So nutritional management, this is largely, I rely on my pancreatology colleagues to manage nutrition and pancreatic enzyme replacement therapy, and then ongoing needs over the long term, particularly fat-soluble vitamins, folate, iron, vitamin B12, and these all really need to be watched long term after TPIAT, critically important. Now, pain management is extremely important because patients with chronic disease of any type have substantial pain and pain psychology burdens. And so what is very important, and we really work hard toward, is assuring good prehabilitation. So in other words, addressing these components prior to proceeding to the operating room for a TPIAT. And that is inclusive of pain anesthesiology, a pain team approaches, particularly medication management that includes non-opioid approaches, pain psychology, so pain coping and functional assessment, cognitive behavioral therapy, and physical therapy. Our endocrine management, we have a couple very great lead endocrinologists as part of our TPIAT team. We also have a diabetes insulin inpatient service consult team, a DISC team, that really helps to manage all of our TPIAT patients, as well as blood sugars on all patients with insulin needs in our hospital. And so this is really hour-to-hour management by an APP service in our hospital. Endocrine management, again, I mentioned the very, very tight sort of goal ranges for our blood sugar, so 80 to 120. As I mentioned, islets don't start to function right away. They've gone through lots of stressors. They don't have vasculature that needs to be, that over time neovascularization will occur, substantial hypoxic stressors, osmotic stressors, et cetera. And so really tight glucose control is very important to protect from toxic hyperglycemia. So as I mentioned earlier, there are a number of studies, mostly in animal models, that signify the importance of avoiding hyperglycemia to ensure islet survival and engraftment. Endocrine management over time, again, of course, we rely on our endocrine colleagues to manage this. And so weaning of insulin occurs over time. These are just the criteria that they look at in terms of fasting blood sugars, postprandial blood sugars, hemoglobin A1Cs, to assess for ability to back off on exogenous insulin therapy. Hematology, anticoagulation management, I mentioned already. I mentioned the use of dextran for all of these reasons here. That's for 48 hours. And then we do utilize aspirin after dextran. And for extreme thrombocytosis, we do utilize hydroxyurea. Typically, aspirin and hydroxyurea are continued for a few months after TPIAT and ultimately can be weaned off. And we do follow platelet counts as needed to address hydroxyurea dosing. So what about outcomes? So outcomes in children. So this is a paper from about 12 years ago now that is from the Minnesota group that highlights on the left here prevalence of opioid use, and you can see after TPIAT in 75 patients a pretty substantial decrease that occurs over the first 6 to 12 months. And so you can see opioid use decreases substantially. And then you can see on the right side, pancreatitis pain also decreases substantially in the first 6 months or so. And these effects are sustained over time, as you can see by these graphs. Now, insulin function, islet function, and glycemic control from this study, there is this study highlighted sort of a dichotomy. So you can see here at 12 months after TPIAT, children that were between 13 and 19 had an insulin independence of around 35% or so at 12 months. But if you look at those that were younger than 12, insulin independence was much higher at over 50% at 12 months. So younger children are more likely to achieve insulin independence after TPIAT. And in fact, insulin independence was reported here in this paper as long as 10 years post-TPIAT. Actually, there are adults that are post-TPIAT for over 2 decades that have remained insulin independent. But clearly, we need longer-term outcomes in children. This highlights the importance of insulin independence as a prognostic indicator, islet mass described by islet equivalents, so islet equivalents per kilogram body weight as a predictor of insulin independence. So effectively, the higher the islet yield, the higher the chance of insulin independence after TPIAT. This is not universal, though. I've had patients that have had very, very high yields that never became insulin independent. And then I've had children that were very low, about 25 or 2,700 islet equivalents per kilogram body weight that did achieve insulin independence. So it's not just about the number. This is a paper highlighting the much younger cohort, children up to 8 years of age. And you can see here most of these children had the genetic risk factors, a very good islet yield, all had pain relief by a year and were free of opioids by a median of 68 days. And in this series, over 80% of these young children achieved a period of insulin independence. And at the most recent follow-up before this was published, about 2/3 of children under 8 were still insulin independent, compared to about 40% in the cohort over 9 years of age. So clearly, younger children seem to do better with regard to insulin independence, but we need longer-term follow-up, of course. So why do younger children do better? There are a number of theories, a number of hypotheses. Younger children do have lower insulin demands, so perhaps it's a better metabolic milieu for engraftment. There's some evidence that the beta cells from the pancreas of a young child have a potential to replicate. So, are these beta cells potentially replicating in the liver after autotransplantation? That's as another hypothesis. And then there's also been published studies regarding remnants of ductal origin. Again, remember that islet prep is not purely islets, but there are stem cells, there are remnants of ductal origin, et cetera. And there may be some islet neogenesis that occurs from cells of ductal origin after autotransplantation. So as I mentioned, insulin independence largely correlates with islet yield, so islet equivalents per kilogram body weight. And there's a relationship between islet yield and a number of factors. These are all from retrospective studies. So worse imaging findings, so more atrophy, more calcifications, more ductal dilation leads to lower islet yield. Longer duration of symptoms typically leads to lower islet yield. And then degree of disease from a histopathologic perspective, so degree of fibrosis or acinar atrophy. So more fibrosis correlates with lower islet yield. Of course, this is a post hoc analysis. We typically are not biopsying the pancreas prior to TPIAT. But the point is that there are a number of factors that we probably need to be considering when we talk about patient selection and timing of TPIAT. Importantly, a prior ductal drainage procedure and a prior resection reduce islet yield and decrease the probability of insulin independence. And so we have to be very cautious in terms of the children in particular that are most likely to not respond over the long term to conventional operations. So those with genetic risk factors in terms of offering these rather than a TPIT. So really we have to be very, very careful about these operations in patients that are at the highest anticipated need for future TPIT. So what do we know from the prospective observational study of TPIT? A couple of papers came out last year. And so the post study is a multi-center consortium closed to enrollment a few years ago with the goal of enrolling up to 400 patients. We nearly reached that. And the goal here was to look at patient and disease characteristics that were associated with the most favorable pain and quality of life outcomes and with favorable glycemic outcomes, trying to understand optimal timing of TPIT, et cetera. And so this is the study looking at pain and quality of life outcomes. And so 384 patients, 255 were adults, 129 children. So there was a significant decrease in opioid use, daily abdominal pain, and mean pain scores at 1 year. Pre-TPIT opioid use was associated with a 9-fold higher odds of opioid use at 1 year. And the odds of opioid use at 1 year increased as age increased up to 40 years and then plateaued. And then, of course, age and daily opioid use pre-TPIT also predicted daily opioid use at 1 year. Higher quality of life scores at 1 year were associated with higher scores pre-TPIT and with younger age. So implications here, really that daily opioid use should not be viewed as a contraindication to TPIT because many of these patients are weaned off of opioids by 1 year, but rather we really should be thinking about earlier timing of TPIT rather than waiting. This is the endocrine outcomes paper, sort of the sister paper, so to speak, same cohort. At 1 year after TPIT, there were 20% of patients were insulin independent, with 83% retaining islet function. Pediatric age and lower baseline hemoglobin A1C were significant predictors of insulin independence at 1 year. And baseline fasting C-peptide, so more C-peptide at baseline and lower hemoglobin A1C were associated with islet graft function in general. And patients with diabetes before TPIT, which were 15% of the cohort, were never weaned off of insulin at 1 year and certainly required higher dose of insulin after TPIT, but islet function was preserved in approximately 50% of those patients. And in those with pre-diabetes before TPIT, so 24% of the cohort, 15% actually achieved insulin independence at 1 year after TPIT. So the implications here are really TPIT should be considered in children suffering debilitating pancreatitis, and to think about the potential advantage of proceeding with TPIT before significant compromise in metabolic function. What about long-term outcomes in children after TPIT? We clearly need more data. This is a retrospective study published a number of years ago. I will caution you, the caveat here is that this was predominantly adults and only 30 children out of the 215. So predominantly adult study. So that's the caveat here. But this is really the longest term follow-up paper, a greater than 10-year follow-up. You can see here that over 10 years, there was a durability in pain outcomes, durability in pain resolution, and durability in opioid wean. Again, these are adult outcomes. I want you to take that as a caveat here. Glycemic outcomes in this paper at 10 years. As you can see here on the left, there is attrition of islet function over time. and insulin independence at 10 years was about 20%, with partial function in another 32%. And you can see here on the right, importantly, a higher islet mass auto-transplanted was the strongest predictor of islet graft function, and children were more likely to have islet function than adults. But clearly, we need longer-term outcomes in children. So where are we going in the future? And so this, I highlight this paper as an algorithm from a decision-making approach. And I was honored to lead this paper with through NASPGHAN Pancreas Committee a number of years ago that really highlights an algorithm for operative decision-making for chronic pancreatitis in children. And it incorporates pancreatic duct size, the uniformity of ductal dilation, but importantly introduces the concept of genetic risk factors in terms of how we determine what may be the best operation to offer. And so the presence of a genetic risk factor does elevate consideration to TPIAT rather than surgical drainage operations or pancreatic head operations. Now, what else are we doing to expand offerings of TPIAT in children? And so this is a patient I took care of that had developed extensive extrahepatic portal vein thrombosis, actually extending all the way up into the liver, that had substantial varices around the pancreatic head because of that portal vein thrombosis. And so in order to proceed, but clearly met debilitation criteria and poor quality of life criteria for TPIAT. But in order to proceed with the TPIAT, we had to ensure that there was a manner to get mesenteric venous flow back up to the liver. And so what we did was a two-stage operation where we utilized a cryopreserved vein to sew from the supramesenteric vein to a large varix up on the liver side to basically ensure that we would be able to preserve mesenteric return up to the liver through this shunt. And then ultimately, a week later, we proceeded with TPIAT after these varices were decompressed and the shunt remained patent. And so we removed that pancreas and we shortened the shunt, of course, at that time because the pancreas was no longer there. And so to mitigate a kinking situation, we shortened the shunt and proceeded with TPIAT in this patient successfully. And he's done fantastic and has been off of opioids with great quality of life. Does still require insulin, did not achieve insulin independence. These islets we did place entirely extrahepatically because of the substantial portal vein thrombosis issue, but has a dramatically improved quality of life. And what about age? So how young is too young? So this was a patient that we cared for quite a long time, presented at 4 months of age with pancreatic ascites and pancreatic ductal disruption. Had a hereditary pancreatitis panel with a CFTR mutation, a variant of unknown significance. Underwent several ERCPs to try to identify pancreatic duct effectively. There was no duct present that we could identify in the head of the pancreas, and had 11 subsequent months of refractory pancreatitis despite maximal therapy. Had 10 readmissions over this time frame, recurrent ascites, actually developed abdominal compartment syndrome for which we had to operate and put drainage catheters in, et cetera. Long-term TPN dependence, was clearly debilitated, and over this time developed progressive chronic pancreatitis with a very substantial irregular dilation of the pancreatic duct in the body and tail with side branch ectasia, continued absence of any pancreatic duct in the head of the pancreas. And so ultimately, this patient was deemed appropriate due to the debilitation for TPIAT. We performed this TPIAT via actually spleen preserving, in this case at 15 months of age, with an excellent islet yield of over 8,000 islet equivalents per kilogram body weight, was discharged at just under 3 weeks post-op, and has done remarkably well. Was weaned off of TPN by the end of the hospitalization, and has been improving PO intake, and we're weaning tube feeds. And really, this highlights the technical feasibility of TPIAT in very young children, and really age alone should not preclude consideration for TPIAT. So what about too late? How do we define too late? It's hard to define too late, but we certainly don't want to offer a big operation like this too late in the game. And so there's the concept of central sensitization. So due to duration and intensity of peripheral stimuli, ultimately the pain transmission from the end organ up to the brain is no longer coupled to the actual stimuli. And so patients develop hyperalgesia or allodynia. If central sensitization develops over time because of the chronic pain, that may predict failure actually of opioid weaning and pain relief after TPIAT. So we need to get better at defining central sensitization because we don't want to offer a big operation when we have a low chance of achieving improvement in quality of life and weaning of opioids. So some of the things that we are working on in the field are utilizing quantitative sensory testing to really assess when and whether a patient has reached central sensitization. And so this is a novel tool that we are soon to be validating in the pediatric population. What about predicting glycemic outcomes? So how do we predict glycemic outcomes prior to TPIAT? And so this is one model, the HOMA beta score, which really takes preoperative fasting glucose and insulin values to try to be a predictor of ultimate weaning of exogenous insulin. And it did in this model from the Johns Hopkins group. It did perform quite well in their model, in their population. What about predicting islet function and damage? So lots of work being done to assess functional quality of islets. It's not just about the number, but it's about their functional quality. And also work that has been done, particularly out of the Baylor group, looking at predictors of islet damage, microRNA 375 as one in particular. And so in their studies, a lower microRNA 375 released during islet isolation correlated with better glycemic control post-TPIAT. And then what about non-hepatic implantation sites to avoid the instant blood-mediated inflammatory response and local islet injury from autotransplantation into the liver? And so work needs to be done to assess alternative sites as well. This is one alternative site for islet autotransplant. I mentioned this earlier in the talk, which is the use of an omental envelope, so sewing together the omentum with islets implanted within as a little omental enchilada or islet enchilada, I might call it. We also need more clinical trials. There's no magic bullet in terms of optimization of engraftment and function or alternative sites. So we clearly need additional clinical trials down the line. So to conclude, a comprehensive multidisciplinary team approach is critical to ensure optimal outcomes in debilitating pancreatitis. Selection of operation must be based on disease and morphologic anatomic characteristics. And I would submit the presence or absence of genetic risk factors. In appropriately selected children, TPIAT does achieve durable pain relief and improves quality of life with manageable glycemic control. And we certainly need much more research. So research needed to develop predictive models for failure of weaning of opioids and improvement in quality of life. And research particularly is needed for optimization of islet engraftment, function, and durability, as well as biomarkers to predict islet insulin weaning. So with that, I'll conclude. There are questions. I'm happy to receive them via email as on the screen. And I really would like to thank again the National Pancreas Foundation for allowing me the opportunity to present today. Thanks very much.